Hello there and welcome to another CPD talk. My name is Jasmine and I'm a senior in blood transfusion. Today we're going to be talking about batch products, also known as blood products. We're going to go through what they are, what their purpose is and when they're used. So what we're going to cover today is, as I said, what a batch product is, the different types of batch products, the indications for each product and contraindications, and are there any risks associated with the transfusion of these products? So, blood transfusion, we have two different types of blood derivatives that we monitor and issue. These are split up between blood components such as red blood cells, fresh frozen plasma, platelets and cryoprecipitate, and blood products, more commonly known as batch products such as Beriplex, Prophylactic anti-D, Octaplas or other coagulation factors. Batch products differ blood components for several reasons. Batch products are normally derived from over 1,000 donor samples. This will vary depending on the product. They are normally only derived from plasma and are manufactured in plasma fractionation facilities instead of within a blood centre. And finally, because of the number of donors and therefore the small amount of exposure to each donor that a patient would have during a normal infusion of the product, as well as the manufacturing process, the risks of serious adverse reactions are very, very, very small. So there's a lot lower risk of having a serious adverse reaction with a batch product than there is with a blood component. Batch products therefore have different rules and regulations, most of which are less stringent than for blood components. So blood components, because of BSQR and MHRA, we have to have end-to-end traceability. That means we have to know what happens to it when it first goes into the blood centre to when it's given to the patient. We have to know what temperature it's stored at, we have to know whether it's transfused or wasted, and we have to know that on all blood components that we see in the lab. Batch products don't have the same regulations, so while we try to ensure that we have that end-to-end traceability, we won't spend as long chasing what's happened to it once it's left the laboratory. We will just ensure that we and the manufacturer have stored it at the correct temperature. Not only that, but unlike blood components, the majority of batch products do not require compatibility testing before issues, so they won't have an assigned blood group associated with them, and that's most of them, not all of them, which means that we don't normally need to have a patient group and save before we issue the product. There may be some circumstances where we ask for one, and that's because in order for that patient to require the batch product, they're probably going to be in a place where they're bleeding and therefore may require blood. So we might ask for a group and save sample so that if they need the blood, we can provide it. But for most batch products, we do not need a group and save sample before issue. So what types of batch products are there? There are sort of three main types of batch products that are used in blood transfusion. The first one is a batch product made from immunoglobulin, and specifically we issue prophylactic anti-D. Immunoglobulins are supplied by pharmacy for different things, but in blood transfusion we only issue anti-D. The next one is coagulation factors. So each laboratory will stock different factors, and that will be down to several reasons. The first will be if you have a haemophilia centre that's close by, you will try to stock the same products as them because their patients will be on named products and they should continue those products if they go to different hospitals if possible. And different haemophilia centres will stock different brands or products for the same reason. The other may be to do with costing, and finally to do with availability. And the final type of batch products is human albumin solution. So this historically was issued in blood transfusion. however, is not normally found in the transfusion laboratory anymore. It's kept in pharmacy, so I'm not going to discuss that in this talk. So we're going to start with immunoglobulin. So almost every transfusion laboratory will stock prophylactic anti-D. It comes in many different doses. This would be categorized as a specific immunoglobulin. So it's made from selected donors with a high antibody level to the target of treatment. So in this case, D. So they would have high levels of anti-D in their system. Prophylactic anti-D is given to patients to prevent them from creating their own immune anti-D. And it does this by attaching 20 foreign cells in the patient's blood which hold the D antigen before the patient's immune system can react and create its own antibody. Most commonly this is used during pregnancies of Rhd negative women, and I will go through that later. The next thing we want to talk about is the coagulation factors. So this group of batch products accounts for the remaining types of products that we keep in the laboratory. Most laboratories will hold Beriplex, which contains factor 2, 7, 9 and 10. Octaplas, also known as solvent detergent FFP, which gives a more standard amount of coagulation factors and has a reduced risk of thromboembolism. And finally, single factor concentrates for the treatment of most inherited coagulation deficiencies, except for factor 5 and factor 2. Beriplex is known as prothrombin complex concentrate, or PCC. It is the treatment of choice for the immediate reversal of warfarin in patients who are bleeding or who are going to go to surgery. Octaplas has reduced risks of infection and TRALI for patients who use this over FFP, however has reduced levels of coagulation factors when compared with the standard FFP. Normally it's recommended for TTP sufferers. So Octaplas, the most comparable product to it would be FFP. And they can sometimes be interchangeable, but there are some benefits to choosing one over the other depending on the case. And finally, single coagulation factors tend to be used for the treatment of haemophilia A or B, depending on the factor that they're supplying, and von Willebrand's disease. They can be used to help patients on a daily basis, so just to maintain the correct levels of these factors and be able to go about their days, or in emergencies where there's a high risk of bleeding, so they're going to surgery or they've been in an accident. We're now going to go through the indications of batch products, starting with anti-D. So prophylactic anti-D should be given when the patient is Rhd negative and meets one of the following criteria. So they've been given Rhd positive platelets. The reason that you would give prophylactic anti-D for patients been given Rhd positive platelets is because platelets can contain very, very small amount of red blood cells within the packs. In an emergency situation, if you have someone who's bleeding and they need platelets, some labs only stock Rhd positive platelets, in which case they may need to give the positive platelets to a negative patient. If they do this, then you can give the prophylactic anti-D, as it will go in and attach to any possible red blood cells in that pack and coat them with this anti-D that will prevent the patient from creating their own immune antibody. And normally this would be given to patients who don't want to create anti-D, so patients of childbearing age, children, patients who are multiply transfused, possibly, because it will make it more complicated to give them blood, but it will be down to your laboratory's procedure as to how and when that's issued in that circumstance. The next, in the most common use of prophylactic anti-D, is for pregnant women who are Rhd negative and have a potentially sensitizing event. So a potentially sensitizing event is anything where they are exposed to a foreign antigen and therefore could create an antibody. So when you're talking about pregnant ladies, that foreign antigen is coming from their fetus and it's an exposure to their red blood cells. So examples of this could be an abortion, an antenatal partum hemorrhage, so an APH, a road traffic accident, surgical intervention, or even birth, because obviously when you give birth there's a lot of blood involved. If they are greater than 20 weeks pregnant, then they should be given prophylactic anti-D. The reason that we're most concerned with anti-D and not any of the other possible antibodies they could create is because anti-D is the most common cause of severe HDFN and therefore could cause issues in future pregnancies. Beriplex. As previously mentioned, Beriplex is used for the immediate reversal of warfarin. So the patient should have a high INR. They could be bleeding, going for theatre urgently. The most common one that we get is having an intracranial bleed. Or if the patient is scheduled for theatre, say this afternoon, and they were given vitamin K, but it has not been effective to reduce the INR, then Beriplex could be used. Octaplas. As I said before, Octaplas can be given when a patient has TTP and requires a plasma exchange. So TTP is thrombotic, thrombocytopenic purpura. When in emergency situation, factor concentrates aren't available, so factor 5 and factor 11 concentrates aren't there. And for the reversal of anticoagulant therapy, such as rivaroxaban and dabigatran, where Beriplex would not be effective. Finally, single coagulation factor. These are normally used to help manage haemophilia A, haemophilia B, or von Willebrand's disease, or a combination of the above. There's also a fibrinogen concentrate, factor 1, which at present is only licensed in the UK for the treatment of congenital hyperfibrinogenemia, but can be used for acquired hyperfibrinogenemia, for example, DIC, traumatic hemorrhage, or massive transfusion. We're now going to go through the contraindications, so when they shouldn't be given, starting with anti-D. So the biggest one is if the patient is RHD positive, don't give them prophylactic anti-D, there's no point. If a patient is RHD negative but has intentionally been given RHD positive red blood cells as a transfusion. So I know I mentioned about if you have a patient who's RHD negative and they're given RHD positive platelets, we might give prophylactic anti-D. When you're giving prophylactic anti-D, the first thing is a dose of 1,500 international units will only cover a bleed side of 12 mils. Red blood cells have about 250 mils in them, if not more. So you would have to give a lot of prophylactic anti-D to be able to deal with that amount of red blood cells circulating. Prophylactic anti-D will attach to the red blood cells that you have transfused and will mark them as we need to destroy these because they're foreign. So you're basically going to be undoing all the work that you had done by giving the patient a transfusion of red blood cells. The only time that you would want to use prophylactic anti-D for an RHD negative patient that you've given RHD positive red blood cells is if someone had started a transfusion of these by accident, noticed, stopped, and then you could give the prophylactic anti-D as a way of mopping up any of the red blood cells that were in that patient's system. Otherwise, there's no point. The next one is if an RHD negative woman gives birth to an RHD negative baby, or if at any point during the woman's pregnancy the baby is sent or the fetus has genotyping that shows that they're RHD negative. If the baby doesn't have the D antigen on their red blood cells, then there's no point in giving the patient prophylactic anti-D. It's a waste of time. And finally, if the patient already has immune anti-D, then giving them the prophylactic anti-D is not going to make any difference. Beriplex. The Beriplex should not be given, so these are the definite of when it shouldn't be given, is if the patient is not on oral anticoagulants, if the patient does not have a high INR, and if the patient does not require the immediate reversal of oral anticoagulants. So if the patient is going for surgery in a week's time and they're on warfarin, then you can stop the warfarin and give vitamin K. You have enough time to do that. Beriplex should only be used for immediate reversals. It should then be avoided if the patient is on oral anticoagulants that Beriplex is not licensed for the reversal of. I've put a star next to that because there are a lot of new oral anticoagulants that have been around for the past sort of 5 years, and there has been some research that has shown that Beriplex is of help in the reversal of these anticoagulants. However, it will be down to your hospital's protocol as to whether or not Beriplex is given to help in the reversal of those, and there should be a strict procedure in place of when it should be used. And finally, if vitamin K is indicated instead, then vitamin K should be given, not Beriplex. Octaplas. So it should not be given when the patient has a severe protein S deficiency, or if the patient is known to have an IgA deficiency with antibodies against IgA, which is the same for FFP. Octaplas should then be avoided when the patient is known to have a plasma protein allergy, the patient has previously had reactions to FFP because they will likely have reactions to Octaplas, they suffer from pulmonary oedema, or the patient is at risk of thrombotic complications. I've said that it should be avoided because it could be used, but if it is used, then you need to monitor the patient closely. Single coagulation factors should not be given when they do not fit the correct patient group. So, for example, some coagulation factors are not suitable for children, so those factor concentrates should not be issued for children. There will be other producers that have something that's safe for the use of children. If they do not have a factor deficiency, then you shouldn't be using them. The next is if they have a factor inhibitor and the batch product is not specifically designed to work in the presence of this inhibitor. So there are some coagulation factors that say that they are effective with certain inhibitors present, but if you give someone a coagulation factor that does not say this, then the patient's inhibitor will just work on the factor that you are giving them. And they should be avoided when the patient is regularly prescribed one brand of a factor and you're trying to give them a different brand. So as I said before, most patients who require these single factor batch products will be on a specific regimen and they will have their required product that they should be using. And if you have someone come into the hospital, you should be discussing with their clinician whether or not it's acceptable for you to give an alternative because you don't have their specific brand in stock, and that should be the clinician's decision. So what are the risks? While the risks associated with batch products are much lower than with blood components, they are still derived from blood donors, therefore there is still a risk. This is why blood transfusion laboratories will still aim to uphold the same standards of blood traceability with batch products. Not only this, but incidents relating to batch product transfusions should be reported and investigated urgently. So when, as the name suggests, batch products, they're produced in batches and we get given a batch number. And this is why when you are transfusing or issuing a batch product, it's really important that you ensure that the batch that you have issued and assigned to that patient is the batch they are given. If we get a recall on a batch product, it will be on the whole batch because there will be something with that batch. So if you are issuing or you are transfusing a batch product, just double, triple check that the batch numbers match what you are expecting them to be, so that we can recall it, and so that if it is transfused to a patient and there's something wrong with that batch, we can recall the patient as well. So that's all we're sort of going to go through today. So to summarise, blood components come from between 1 to 5 donations of whole blood and are processed in blood centres. Batch products, or blood products on the other hand, are plasma derived and come from greater than 1,000 donations, plus they're manufactured. There are lots of types of batch product, each with their own unique indications and contraindications. Batch products can be safer and faster acting alternatives to some blood components in the correct situations, and batch products should be monitored carefully and have as close to full traceability as possible to ensure the safety of the patient. Hopefully this has been an interesting look at batch products for everyone. Please remember to complete a reflective learning on the CPD talk to make it a robust piece of evidence, and I look forward to next time. Thank you so much for listening. Bye!